So, hello again, everybody. Welcome to the February edition of the Primary Care Direct monthly webinars. Today, our colleagues David Cowan, the Social Prescribing Program Manager, and Anthony Nelson, the Managing Director with Conexus Healthcare, will be taking you through making the most of your social prescribing link worker. Just quickly draw your attention to the Q&A facility at the bottom of the screen. If you hover your cursor over it, you can ask any questions there. We'll try and get to those towards the end of the webinar. If you do have any questions, do fire away. The webinar is being recorded. It will go on the website, and we'll be able to share the slides as well. I know David and Anthony have got a lot of really useful information to get through, so I'll hand over now and enjoy. Thank you.
Excellent, thank you very much. Welcome to Conexus Primary Care Direct Social Prescribing Link Worker course. Webinar. Sorry, so we've got loads of stuff to try and fit in, as Damien was just describing, and we're going to talk through a little bit of stuff around the context. We'll talk about some of the stuff around the model of social prescribing. We'll talk about what kind of social prescribing you're going to do, some of the stuff that we're doing in Wakefield, and then some top tips on planning for success to get the most out of your social prescribing link worker.
David. Thank you, Anthony and Damien. So, hello everyone. Initially, I think it would be useful just to talk through the context within the NHS 10-year plan. We often hear about, the term social prescribing is not new. Certainly, there's a lot of roles that may have been working in the similar type of sector, really trying to work around a kind of holistic model of health. We'll spend a little bit of time talking through some models of what the social prescribing link worker role includes. But initially, what NHS England said they would want to have in place is 1,000 additional trained link workers by 2021. With 900,000 people being able to see social prescribing link workers by 23-24. If you start to unpick some of the detail in that, in terms of the numbers, that's potentially 4,500 link workers by 23-24, which equates to 3.5 whole-time equivalent link workers per primary care network. So if you then start to think about what a generalist offer includes, that's an all-age, all-offer role, which is really where social prescribing comes from, you may start to see a kind of a capacity where we then focus on children and young people, secondary care, other specialist roles in addition to the generalist roles that are already embedded. So that's one potential option around growth as we see things progressing beyond year one over to 23-24. Within this slide, there are a couple of documents that we've embedded. We know that social prescribing is an emerging field, and there are lots of resources out there. We've picked a couple that we think would be really helpful to have a look at. University of Westminster Making Sense of Social Prescribing, and the Social Prescribing and Community-Based Support Summary Guide, which has got lots of information in there, including the Common Outcomes Framework. What are we trying to measure? What are the good elements of social prescribing that we really need to promote? There's a definition there, and that is taken from something that's out there by Public Health England. Really what we're saying with social prescribing, it's trying to work with people in a holistic way, trying to help GPs and other healthcare professionals have a range of people who they can support patients to engage with around non-clinical services. Often they're described as a link worker, a connector, a number of different job titles out there. Really, social prescribing is about addressing people's needs in a holistic way. Just progress. So, what's the latest impact in terms of evidence? I think this particular study is quite useful to refer to. It's got a sample size of 630 patients who completed a survey. And I think one of the things that's come out of this BMJ study is the increase in terms of well-being, positive improvements, decreased feelings of loneliness, Lots of evidence linking, loneliness to impact on our health and well-being. But alongside this, a 25% reduction in healthcare appointments. I think particularly interesting how they have been able to evidence that. In terms of longer studies, we know that this is an emerging evidence base, but trying to kind of look at that long term, I think that's of interest. Lots of people are spending quite a bit of time trying to gather this evidence at the moment. So there are some key elements of social prescribing, and if you refer to the social prescribing summary guide, this is one of the models within that framework. Of course, social prescribing link workers employed to give time as part of a primary care network, outlined within the centre of that model. Those are the key roles that we want to try and support to land well. So what does that mean? Well, it does mean that they need training. We'll be coming a little bit to training later on, but it's about a kind of wider workforce development. There are a number of different roles within the kind of primary care network, and we'll talk through a couple of examples of this kind of social prescribing stroke active signposting model. But in terms of workforce development, we think it's really about investing in peer support, face-to-face training, online training, accredited training. There are a number of different elements out there. The Common Outcomes Framework is really about measuring the impact on the individual, the community groups, and the wider system at large. So within the Common Outcomes Framework, there are a number of different tools. ONS4, patient activation measure are cited as examples of tools to measure individual patient well-being. There are examples of how to look at measuring the impact on the system at large, secondary care, 999 calls, repeat contacts with patients in primary care, etc. And then, of course, looking at the impact on the community groups. What matters to me, and creating a tailored plan. We know that that's certainly something that social prescribing holds dear to their heart, not trying to kind of do to others, more about listening to really what are their key priorities, enabling them to realise their goals. The support for the community groups that I mentioned just in terms of the Common Outcomes Framework is an area that's receiving a lot of interest, especially around the National Academy of Social Prescribing at the moment, who are really looking at how can we ensure that there's enough support for the social prescription. So rather than just spending all of our resources on employing lots of link workers and having, if you like, lots of travel agents without any destinations to go to, it wouldn't be a great travel agent. Similarly with a link worker, if we don't have enough of the social prescription, we are going to receive a bit of saturation in terms of the numbers of people referring. So support for the community groups and the National Academy of Social Prescribing is quite high on the agenda. The collaborative commissioning and partnership working is really just trying to sort of say, look, it works really well if you build on an existing social prescribing scheme. We'll talk a little bit about the modelling Wakefield in a little while, but it certainly helps to build on what you've already got in place. In terms of easy referral from all local agencies, that is one of the key tricks, if you like, to kind of make the most of your link worker. We need to ensure that patients can get direct access to a link worker without the need to see a GP first. That really ensures patients can choose what they need to get the best support, but they also need to know what is available when they contact primary care. So we'll talk about that in a short while, but certainly it's one of the key elements within the social prescribing framework. So at Conexus Healthcare, we spent quite a lot of time working on a number of roles, and two of those main roles that we've been investing our time in training and development is active signposting and social prescribing a level 3 qualification. Within this model, there is a document that I've sort of cite, which is Kimberley 2015, and really he sort of outlines 4 levels of social prescribing. So what kind of social prescribing are you doing? Some describe active signposting as the first level of social prescribing. Certainly within Kimberley's framework, it's that first tier, online access to community activities, helping patients when they contact primary care get to the most appropriate healthcare professional without the need to see a clinician first. There is an emerging evidence base. It can just be as simple as a leaflet in a GP practice or a text message with some information about what's available locally, but no link worker. Kimberly then describes social prescribing light as his second level of social prescribing, with often a voluntary sector organisation acting as a bit of a point of contact. They will hold a database perhaps of information that's going on locally. A professional might ring up, get a bit of information. They could be seen as a social prescribing light, sort of level 2. We know that social prescribing medium has been in place with a number of roles. You might have seen a health-focused kind of health trainer model locally, focusing on diet, nutrition, with a CBT element around behaviour change, signposting to the voluntary sector and self-help groups, but not focused on the beneficiary needs in a holistic way with a kind of full sort of wraparound offer. So Kimberly describes social prescribing holistic as direct primary care referral to social prescribing. So they're embedded within a primary care network. They are employing link workers who work in a holistic way to provide a full sort of assessment of need, not really coming with a kind of sort of formula of we need you to engage with this particular kind of exercise model and follow this particular regime of nutrition to improve your health and well-being. It's very much about what matters to the individual. No limit on number of sessions, and that's going to be a challenge, especially when you're looking at 250 referrals per whole-time equivalent per year. If you actually start mapping that out, that could be 4 visits. If you said 4 visits, over a 46 working week year, that's about 4.5 visits a day, every day of the week, without doing anything else. So we know that there's a challenge there between doing social prescribing well and hitting some of the targets, but that's something to be aware of. There's other factors that they'll need to have: MDT attendance, there'll be other personal development training opportunities, and getting out into the community as well. So those are some of the challenges, but we know that social prescribing holistic is where we're really focusing our energies. Okay, so what difference do you want your social prescribing link worker to make? We want to reduce demand in primary care services. We want to reduce demand for secondary care services. We want to improve the patient's well-being. Ultimately, that's one of our key objectives. So let's have a little bit of a look further at what that means in terms of Yorkshire and Humber. We know that one of the evaluations that has come out was led by Dr. Chris Dayson. So Dr. Chris Dayson is based at Sheffield Hallam University, and he has been responsible for a number of evaluations, probably considered one of the sort of leading academic thinkers around social prescribing evaluations. One of his most recent pieces of work has been in Bradford. Is actually in the process of publishing some further follow-up work on HALE, which is the Community Connector scheme, or the social prescribing service in Bradford. So in terms of the Common Outcomes Framework, we're trying to measure the improvement of well-being on the individual, one of the 3 elements that we're trying to measure. And actually in Bradford, there is an improvement of 0.4 points on the SwimWeb score. So for people not familiar with that term, that's Short Warwick Edinburgh Mental Wellbeing Scale. It's a tool that's often used to measure patients' individual well-being. It also comes with an attached return on investment. So you can equate improvement in well-being to a reduction in use of health services. So the proportion of clients whose SwimWeb score improved at 3 to 6 months was 74%. So that's pretty good impact, quite similar to some of the things that we saw in Wakefield, actually. So quite a good impact. And on the right, you can just see there's the evaluation of the scheme for further reading. So moving on, in terms of reduction demand for primary care services as well, we know within the South Yorkshire area that there's been a reduction of 7% overall in the total demand on primary care services at baseline and at follow-up, which was 3 months after the initial referral. And then we've got 6% reduction at 6 months after follow-up. I think this is going to be interesting, you know, looking longer term. Of course, we need longer term studies in place to be able to continue to contribute towards this evidence base. But certainly that's you know, a good win in terms of reduction in demand on primary care services. And of course, yes, you've got the full evaluation for anybody who wants to have some further reading. So I think really this is where the focus initially came around evaluations in 2014-15 when Dr. Dason's published this particular report. Rotherham was very focused in terms of their target population. So they used the risk profile, and the risk profile was a tool that was able to identify patients high at risk of planned admission and A&E attendance, contacting primary care. And through an algorithm, the tool calculates a patient's risk profile. Using that risk profile, they were able then to target specific groups and then provide a social prescribing intervention. What's been really interesting is their equated return on investment. Also, so initially, the emergency inpatient spells were reduced by 6%. And accident emergency admissions were reduced by 13%. The estimated cost was 647,000. So on an initial return on investment, you were seeing 35 pence for every pound invested. And I think what's particularly interesting here is when we start to think about making social prescribing cost neutral. So we can certainly say that at this stage, if we can sustain those reductions up to 3 years, then actually social prescribing is cost neutral. But one of the interesting things about what Dr. Dason says is that it's actually having a bit of a wider impact on the ecosystem. And I think that's really interesting, trying to look at the kind of holistic model. It would be great now to talk about what's going on in Wakefield. We've got some fantastic social prescribing link workers here. We've been meeting them very recently and just seeing the team grow has been brilliant. I think the thing to say with Live Well Wakefield is that it's quite a wide-ranging model with a number of key stakeholders involved. So it's actually commissioned by Public Health Wakefield. The lead organisation is NOVA, Wakefield District. So that's the CVS voluntary sector organisation for Wakefield. And then staff who are employed through South West Yorkshire Partnership NHS Foundation Trust. So the team has been around now for about 10 years. In fact, 11 years. It started as a kind of a team around health and well-being and have grown to include the social prescribing offer. Within that full offer, the Live Well service in Wakefield is actually open to anybody 18 plus. So that's a great advantage. Some social prescribing services are focusing on a particular age group, 50 plus. But we know in terms of need, patients 18 plus are going to benefit from social prescribing. So the fact that there's an old age offer from 18 plus is really important. What does the service deliver? Well, through one-to-one support with Live Well advisors, they're able to provide contacting surgeries, contacting patients' homes, and also with the support of volunteers through a self-management program, they're able to focus on some of the interests within those local communities, some of those local assets. And whatever people are interested in locally, they may volunteer to set up a walking group or an art group, or they've got a lived experience in diabetes and want to contribute towards a diabetes workshop and support group. So the fact that the one-to-one support with the link workers is also benefiting from this kind of wraparound volunteer offer within the self-management program. It's a real plus for Wakefield. The small grants program is something I mentioned earlier, a little bit around the common outcomes framework. The key elements is this support for community groups. So we'll talk a little bit more about that in a second. And then stroke reviews. So what the brilliant thing is about the kind of Live Well offer is that they've got these stroke reviews available for patients 6 months post-stroke. And again, it's quite a holistic assessment of need.
What's really interesting about the Live Well Wakefield service is the fact that because it was already in existence and it already had a robust model, a good evidence base and some really good outcomes, and was well respected and regarded in the local communities, that all the primary care networks in Wakefield, all 7 of them, have commissioned Live Well Wakefield to deliver their primary care network social prescribing link worker service. And that's been a real boon to getting those primary care networks accelerated with their use of social prescribing link worker resource.
Yeah, that's a really good point, and quite lucky to have that in place in Wakefield. Live Well Wakefield uses the 5 ways to wellbeing approach. This is an evidence-based new economics foundation model, which really just says if you focus on these 5 key areas, you're going to have a much better chance of improving your well-being. That is enhanced by a full a model, I think is what I describe it as. The significant percentage of the overall budget in Wakefield for the Live Well service is actually focused on providing small grants to capacity build the third sector. So it's this kind of, this analogy around we need people to have a group when they go to a link worker. If there's no groups when they go and see a link worker, there's nothing for them to offer. So it's about that capacity build approach using community assets. There is a complex interplay between these assets and health-related behaviour, and we're really trying to focus on a salutogenic model or a creating health model, rather than trying to cure illness and disease, which is the pathogenic model. So that's a little bit about the asset-based approach that we have in Wakefield. I think at this stage, really, we want to sort of focus on some key tips, some things that you want to take away, and give you an opportunity to sort of prepare some questions. If you've already fired a few into the chat box, I'm sure that Damien will be about to share those with us. But really, I think there's some key points. Just want to sort of hand over to Anthony so that you can summarise where we're at.
Yeah, thank you.
Cheers.
So. What I think what we've learned in Wakefield and what David's trying to rattle us through there is it's really important to have some kind of structure for your service and some kind of meaning and a clear vision for what your link workers are actually going to do. And what's the model that you're looking at? Are you looking at that really low-key navigation, or are you actually trying to make the most of your resource in the area to really robustly develop that higher level of social prescribing link worker function to support your local populations? If you can build on a model that is already in place, if you've got a service locally that is, even if it's only 50% of the way to where you need it to be, how can you use your resource and work closely with that service to enable the whole population across your district to be able to access really good quality, vision-driven social prescribing services? There's something that's really interesting debate at the moment around what does a social prescriber look like? What's the key skill set for a link worker? And whilst there's some really important stuff, and David's going to talk about some training available in a second, there is something about if you make the workforce too professional and you set the barrier to entry is really, really high, what you miss then is some of the opportunities to support people with lived experience, to support people with diverse experiences and backgrounds into your social prescribing link worker service. And bear in mind that these people who are going to be doing this work are going to be working with the widest possible group in your communities, and actually having a diverse workforce enables you to target that support in the most appropriate way. You can find people who members of your local population are going to be able to work with. Just throwing some link workers into the local health and care mix doesn't really help you. They'll constantly, people won't understand what they're there for, how they work, what they're supposed to be doing. So there's something about really working with the local system, with the local community and third sector, working with your practices, working with your community services and hospital services, the primary care, the public health services, for everybody to have a shared understanding of what those link workers that you're actually engaging with and you're employing are actually going to be doing. So the more you can help the system to be able to work with the link workers, the better you are going to be able to most quickly make the most benefit from having those link workers in place. recognise that developing relationships takes time. It's really important that your link workers know who they should be connecting with in their locality, having the time to be able to go outside the usual suspects to develop relationships with anchor groups in the communities, with the small charity or voluntary sector service that's doing something in down one street in one part of the estate, and nobody really knows that it's going on. Really important to be able to take some of the time around doing that, and then investing in training and continued professional development for those link workers. They need to know that they're developing their skills. You'll attract the workforce, and actually that workforce will be more effective. David, tell us about some training.
Yeah, so just to summarise the two training offers that were currently available: online accredited training for care navigating staff with localised training based on what are the services you have available within your primary care network. That's a kind of well-tested model with about 30% of coverage around England and Wales. We have a social prescribing level 3 qualification, the only qualification available for link workers in the country. Covers 9 units, a variety of different elements, approaches that we've brought in partnership with Bromley by Bow, University of East London, and Conexus Healthcare. So it's certainly a full offer in terms of the variety of different partners that you get from going on that qualification. Lots of experience, lots of academic, practical tools, as well as some of the opportunity to reflect and practice social prescribing skills. I think that's enough for us to say now, and I think we've just got a few minutes for Q&A.
Damien, have we got any questions?
Well, first of all, Anthony, David, thank you. That was really comprehensive. Lots of information in there. Thank you very much. As it happens, it was that comprehensive. No questions yet. What I will say to the attendees is we'll be on here online for another 5 or 10 minutes if you do have any questions. So do fire away through the Q&A facility. If you don't have any questions, not a problem, of course. And I mentioned previously the webinar and the slides will be going on the Primary Care Direct website for the webinar, and we can share the slides out as well. So yeah, no,
Damien, we're quite happy to take questions after the event. So our contact details are in here. So if people have got, looking at it on the website, if you're looking at it on the website now and you've got any questions, please share those with David or myself, and we'd love to engage in a bit of a chat with you.
Fantastic, thanks Anthony. And obviously it's not just by email. Get hold of Anthony and David through Twitter as well, over social media. So if you do have any questions, do fire away. And like I say, we'll be hanging around online for the next 5 or 10 minutes. And thank you for your attendance.
I'm going to stick us on mute.
Yeah, no problem. That's fine, Anthony. If you do have any questions, I will. Well, you'll be able to hear me, so I'll send them.
I will be able to hear you. That's exactly right.
You can now. Anthony, David, Julie has just asked a question. Can she access the courses through the Conexus web? I'm assuming Julie means website.
Yeah, so the Conexus website hosts all our training offer to primary care staff, including the social prescribing, link worker training and the care navigation training. And if people go to our website, which I think is detailed on the first page of the slides, but it's www.conexus-healthcare.org. Then there's a training and education offer is on the website. When you click on the social prescribing one, we've got a new Wizzy website that links you through to, which is done in partnership with the experts that David was mentioning earlier, Bromley by Bow and the University of East London. So they're our partners in delivering the social prescribing level 3 qualification. And if you don't get what you need from either of those websites, there's chat facilities on there. So if you send emails, you can send conversations through to us, and we'll pick those questions up and come back to people. The team here at Conexus will do that.
Thanks, Anthony. That's great. Is it Conexus Healthcare? Conexus-Healthcare. I've just tried that.
So our email addresses that are showing on the slide at the moment, so it's conexus-healthcare.org is the back end of that email address, and the website is simply www.conexus-healthcare.org.
That's great. So Julie, I've put the link on the chat facility. If you wanted to copy and paste that, you can go straight to the website and it'll be on your history. So
excellent.
Hope that's helpful. Excuse me. I know Lindsay's still online as well. I'm not sure if Lindsay has any questions, so we'll probably hang around for a couple more minutes.
Sure thing.
Okay, Lindsay, you're the final attendee, so we'll give you one more minute. If you have any questions, do feel free to fire away. If not, when you do receive the slides, you will get David and Anthony's contact details, so you can ask any questions there. Thank you, Lindsay. Thanks for your message. And you'd like to do level 3. I'm sure if you get in touch with David and Anthony, they can help you out with a bit more information and give you some advice. Enjoy your lunch.
Yeah, no, that's great. Drop us a line. As David says, you can contact us through Twitter. You can send us an email. If you go to the website, there's the opportunity to to connect with us in there. You can also subscribe to our training bulletin. So we send a regular email out to people to share with them what we're doing at the minute.
Thank you very much.
Thank you very much.
Yeah, I think on that note, I'll sign us off. In fact, Anthony, David, just us 3 left now, so that's fine.
Excellent. Perfect. Thank you very much.
Yeah, no, thank you.